Good evening, everyone, and welcome to ISU Smart Learning webinar. And the topic for today is clinical and Doppler-based approaches for AV fistula creation. And it has been the faculty for today's webinar is Dr. Maneesh Sinha and Dr. Krishnaprasad. I would request our president, Dr. Lalit Shah, to please give the opening remarks, followed by Dr. Uttam Mete, who is our secretary, and then I will introduce Dr. Maneesh Sinha.
Yeah, good evening, everyone. It's a great pleasure and honor that such an important topic is there, that clinical and Doppler-based approaches to AV fistula creation. With this, definitely we would become much more wiser than what we are doing at present, so that we learn, and we need to be the best possible as far as the fistula creation is concerned, because of late that I had been seeing and had been discussing all the time that urology is being poached and encroached by non-urologists. So even this fistula, I have seen at many places, the nephrologists have started doing fistula. I have seen many places, many hospitals, the cardiothoracic people are doing the fistula because of whatever reasons, at local reasons they may have. So we must grow to the best one possible as far as the fistula creation is concerned. And I'm sure that this one will become a very, very important step toward that goal. With this, I wish you all the best and congratulate ISU for a wonderful program. Thank you very much.
Thank you, sir. Dr. Uttam Mete.
Okay. Thank you. Good evening, everybody. As the secretary of this of USI, I extend a warm welcome to all of you. And today our welcome to this evening school. And in this evening school, the school principal has will keep us busy for learning AV fistula creation on Doppler based studies or approaches. So, I would be very frank, in PGI, transplant used to be done by the other department, but recently we have started this more than a year now. So definitely, I also have developed a lot of interest. And as you all know that the AV fistula or the vascular access is the lifeline for any patients of PSRD or CKD. So we have to have a good fistula formation. So where to do, which one to do, how to assess the maturation, and how to assess the failure and everything. It has got a clinical as well as some objective assessment, and the most objective way to assess this is the Doppler. I think we're going to discuss about this only, and it is going to help us a lot. And definitely, I am going to learn a lot from this webinar and with these two great faculties, Dr. Maneesh and Dr. Prasad. So thank you, Principal Saheba, for arranging this meeting. And
You've given me a label.
It will be well discussed, and there'll be interactive session. Thank you very much.
Thank you. So it is my great pleasure to introduce Maneesh. Dr. Maneesh Sinha is not only a very good friend, but he's a very good poet. And I think I really admire many of you may not know, but he really, he speaks and he records his poems so well, and they are really on various topics. And I think the best I liked was on daughters. And with that short, he is a senior consultant urologist at NU hospitals in Bangalore, and his areas of work is renal transplant and vascular access. And one more information is that he is also the founder and director of UroSearch. And this is a startup working on urological innovations, and it was awarded the Nidhi Prayas and Startup India Seed Fund grants. So with this small introduction, I ask Maneesh to please take over, and also welcome Dr. Krishnaprasad. And first, we would be listening for half an hour to their recorded video, and then he will guide us through questions and any difficulties or problems we want to pose to him. Yes, Dr. Maneesh, please start.
Thank you, ma'am. Thank you so much. Before we go on to the video, a quick introduction of Dr. Krishnaprasad also. He is our vascular access star at NU hospitals. He's gone and trained himself both in the US and the UK, and he does most of our Doppler work. So with that, I'll request Navneet to please play the pre-recorded video. That I hope it is self-explanatory. We'll take questions after that.
Sure, thank you.
A big thank you to the Indian School of Urology for giving us a chance to have this conversation. Essentially, I will be talking about clinical evaluation, and Dr. Krishnaprasad will be helping us understand how investigations can complement this clinical examination. If a patient is referred to me for an AV fistula, I would choose the ideal site of AVF construction on clinical grounds. In the history, I would ask for the non-dominant hand, any intravenous pricks on that limb, earlier vascular access history, heart disease, and drugs. In the absence of any cardiac disease, I would not insist on an echo.
So while I agree with Maneesh, there are times when I would ask for an echocardiogram right up front. A lot of our patients who require initiation of dialysis, maybe having it done for the first time and coming into contact with the medical field for the first time. So an echocardiography can be useful in unmasking occult cardiac issues. Secondly, a lot of these patients have uremic myocarditis and pericarditis, and this takes some time to resolve. So you need to understand what was their cardiac function before and after the initiation of dialysis. And if they continue to have persistently low ejection fractions, then a fistula is to be avoided in these patients. So I think these were the reasons why I would ask for an echo upfront rather than do it when I have problems.
So there is one situation where I would look at the cardiac history very carefully. If the patient has had an internal mammary artery graft to the heart, then this can cause steel, and I would not use the ipsilateral limb. What is your opinion on this?
So this condition has already been described and is called the coronary subclavian steel syndrome with an incidence of 6.8%. And the fistula, being a low resistance zone, ends up stealing from the high resistance epicardial vessels, and as a result of which the patient develops cardiac or coronary symptoms which worsen during hemodialysis, starting off with dyspnea and can go up all the way to having an arrest during hemodialysis. So we need to take care of this.
Now, there are certain situations where, as the surgeon, you will have to take a call on whether a fistula should be done, deferred, or where it should be done. Now, suppose there is a patient with chronic kidney disease referred for fistula, and he needs a nephrectomy for a 12 centimeter RCC. Now, you would finish the nephrectomy before constructing the fistula, because if there is hypotension during the procedure, your fistula will close. Now, let us take an 83-year-old gentleman who has not been initiated on hemodialysis. Would you consider a radiocephalic fistula in this patient?
So to take that question, we have this gentleman who's very well educated, who clearly understands after I explained to him what are his renal replacement options, and has decided that he would like to be initiated on hemodialysis through a catheter and has no interest in getting an access done. So while the patient was referred to you for a fistula, once I explained to him all his renal replacement options, he has accepted for a catheter. So this is how options can change, though he has been referred for an access, a fistula rather.
Does the fact that his survival on hemodialysis is approximately a year affect your decision?
A very apt point, Maneesh. You need to look at the overall survival, not only of the patient with any other existing comorbidities, but also the longevity of the people in his family, which will give us a rough idea on how long this patient is going to survive, which is obviously going to be worsened by hemodialysis, as you pointed out. So why would I offer a fistula with its associated problems if the vessel quality is poor to an 83-year-old guy? I'd be very happy to have him on a catheter.
You were speaking about a 14-year-old girl in whom you refused an AVF because she was to undergo a transplant in 2 months' time. Can you talk about that patient?
Yes. So if you look at her vascular map on the right, I have at least 4 options for creating a fistula in this girl. But why would I lose my venous real estate so early in her life? I just suggested that she stay on a permacath, which we placed, and 4 months later we transplanted her. and we have preserved her veins for future use.
As a practice at NU, we don't stop clopidogrel and ecosprin. However, there are some of these newer drugs which we do stop for a varying period of time. My question to you is, do you stop antihypertensives on the day of surgery?
Rightly said, Maneesh, antiplatelets, I do not stop because the risk of cardiac events far exceeds, especially in these CKD patients. So therefore, I don't believe in stopping antiplatelets, and I don't stop antihypertensives either.
Now let us assume we have chosen the left upper limb. I will still examine both limbs and make a backup plan in case the AVF fails. I will proceed with evaluating the arteries. I will palpate the left brachial, radial and ulnar arteries. I will look at the pulse volume and palpate for obvious atherosclerosis. I will then do the Allen's test to look for the adequacy of ulnar and radial flow. If there are unequal pulses on both limbs, then I will send for more detailed evaluation of the aortic arch. Now, if I have access to a Doppler, what are the additional questions that the Doppler can answer?
So the Doppler is a very crucial part to my examination before I decide where I make an access. Of course, in addition to the clinical points that you have said. For example, let's look at the vascular map of this patient, and you can see while she has very good veins in the forearm, very poor quality arteries, and I have opted for a left brachiocephalic fistula. And unless I had those depth numbers, I would not be able to tell her that she will also require a superficialization for a left brachiocephalic fistula. So these are conditions where you will find the use of a Doppler very useful. While clinical examination is, I believe, the foundation for before you create an access, I do not do any of my vascular access without adding a Doppler. And as you can see on the image on the left, this lady has very poor quality arteries, even though very good cephalic vein in the forearm. The same image on the right, you can see I've imaged her radial artery, and you can see all the dense atherosclerotic patches. Conversely, while her current option is a left brachiocephalic fistula, you can see how deep the veins are in the numericals I have given up in the left image. And unless you knew this, you would not be able to advise a second stage superficialization for a brachiocephalic fistula for this patient. So this is where I think Doppler plays a very crucial role. Another important finding when you do a Doppler and you're looking at the arteries is a high bifurcation. In about 2 to 7% of patients, the brachial artery bifurcates higher up in the arm, and this can have a very significant impact if you're creating a brachiocephalic fistula.
We now move on to the venous system examination. I believe a clinical examination is adequate to assess arterial inflow and venous outflow. If we have veins that are distensible with a tourniquet, it tells me that they will remodel for adapting to an increased flow. The Schwartz test shown here tells me that there is no venous obstruction. How would you evaluate the veins on a Doppler?
I consider the imaging by Doppler of the venous side of the axis far more important than even the arterial side. On the left of the screen, you can see the Doppler for a patient who has atherosclerotic vessels. Now, these vessels will dilate, may not be as much. You will still get a Schwartz positive, but you can see a definite thickness to these vessels, and these vessels will not mature if you create a fistula in them. Vis-a-vis on the right, I'm showing you a completely compressible and soft vein, which will model very well and create a good fistula.
Now let us move on to the choice of site for AVF construction. I would first, of course, choose the radiocephalic AVF at the wrist. Before I jump to a brachiocephalic, I would evaluate the cephalic vein where the accessory cephalic joins it in the distal forearm. That is point number 2. Very often, there is a dramatic increase in the diameter of the cephalic vein here, and the radial artery is very close by. Then, of course, I would go to the brachiocephalic AVF. Number 4, the brachiobasilic always entails a superficialization, and that would be my next choice. Would you agree with this order?
There may be situations where this order cannot be followed perfectly. On the left, you see this lady who had her right upper limb as being the dominant hand at one point of time. Now she's left dominant, so you needn't have to do it on the same limb either. So I would choose the right limb in this case. And on the right, you see an extremely tortuous cephalic vein in the arm. So while the progression in this patient may be from a radiocephalic to a brachiobasilic, because the tortuosity of the cephalic in the arm precludes the creation of a cephalic fistula, brachiocephalic fistula.
If a graft is available and the cost is not an issue, would you consider a graft instead of a brachiobasilic AVF? And when was the last time that you had to use a graft?
This meta-analysis says it all. The patency of a fistula, a brachiobasilic, is far greater than that of a graft. I don't have anything more to say, and I use grafts extremely judiciously. I think the last one I've done is about 2 years ago. I have only maybe about 4 patients with an upper limb graft.
Okay, understood. So now what is your opinion on snuff box, ulnobasilic and grass AV fistulas?
As regards the snuff box fistula, Maneesh, what we've seen is unless the vessels are extremely good quality, in the sense only hypertensives and not a diabetic patients, these veins don't model so well. So I've not done this for a long time now. And as regards ulnobasilic, there's sufficient evidence in literature which says that the patencies are poorer than the radiocephalic fistulas. Probably we would do it when there are no other options available to the patient. And there are, of course, unless you do a transposition, you have cannulation difficulties. And then coming to the grass fistula, the runoff happens in 2 vessels. Sometimes if both don't model too well, then neither do they have the adequate size, nor do they have the adequate flows to support the hemodialysis. So these are concerns which we need to address in each of these fistulas on a selective basis.
So now let us assume we have the patient on table and discuss some intraoperative techniques. A good rule seems to be not to touch the intima of either the artery or the vein. Why is that?
So as a rule, it is good not to do that, both on the artery and vein, because on the artery, if you have atherosclerotic segments, you will end up peeling off the intima at places, or you will end up causing sufficient damage to initiate a fledgling thrombus, which then can grow. And on the venous side, if you tend to fiddle around with the intima too much or hold it too much, it may be the cause for juxtaanastomotic stenosis in some cases. So in either case, I think these are very clear surgical techniques, vascular techniques, that you don't touch the intima.
We have also seen multiple presentations where we were told not to lift the artery of its bed. Why does this need to be avoided?
There are 2 reasons why you shouldn't do this. Firstly, even at the end of your procedure, when you unclamp the vessels and you have completely mobilized the artery, it takes up the configuration of a camel hump. So think of a camel hump, and then you have the vein sitting on top of this camel hump. So the artery is being mobilized, it goes into spasm, and the orientation is completely unnatural for the creation of a clean, neat flow through the fistula. That's one. And second is coming from an interventionalist point of view. Since I do some of my own interventions on the fistula at a later date, it becomes extremely tough to negotiate the arteriovenous anastomosis in these patients because the artery is completely out of configuration.
When I learned my fistula surgery, we were doing heel to foot anastomosis with what we thought was a good outcome. Now we ensure that the vein lies in a line that results in minimal turbulence. How important is it to ensure this? Very often these arteries have atherosclerotic plaques, and we should take, as a rule, bites on the artery inside out to prevent dissection of the plaques. Do you follow that?
I'll take both the questions. The first one regarding the orientation of the vein. And as you can see in the image on the left, this is not what is classically done in vascular surgery. The vein has been spatulated and it is on the anterior, or if you wish to call it posterior aspect of your incision. It is not at the corner. So this results in lesser torsion on one axis. The torsion on the two other axes continue to be present. And your second point about taking sutures always from the intima of the artery is absolutely perfect, especially in the ones which are atherosclerotic. You can see here I'm doing the very same thing, taking the bite from the intima of the artery to outside. In fact, in places where I think the intima has got elevated, I even put down tacking sutures using 7-O-proline through and through the intimal patch, and the suture lies on the outside of the arterial lumen.
Now, while checking for hemostasis, there are two things that I do. I release the distal clamp first, and this allows us to see for hemostasis with a lower flow. I also wrap the anastomosis with a gauze piece and wait for 5 minutes, which of course is the longest 5 minutes in my life, but it prevents a lot of unnecessary figure of 8 sutures. What is your opinion on this?
So these two videos show exactly what you have described. On the left, the sequence of clamp removal, exactly mimicking what you said, on the low pressure end first. And on the video on the right, you're seeing that just keeping a gauze for about a couple of minutes takes care of the hemostasis. I have hardly used a hemostatic stitch over the last year or maybe longer.
Now let us assume the anastomosis is done, there is no bleeding. I will check for a thrill immediately distal to the anastomosis. A good thrill as the first palpable sensation suggests a good AVF. Questions to you are, would you do additional tests at this point? And would you accept a palpable pulse or only an audible bruit as a satisfactory result?
So I'll take your first question a bit later about what other imaging I will use. It's obviously the Doppler, but what I'm going to do I will explain a bit later. The second part of your question was, am I happy with just a bruit? Yes, if I get a continuous bruit which is gradually reducing from the site of anastomosis, I'm happy even if I don't feel a thrill. But I definitely will agree with you that I do not like a pulse. Look at the two images on the top left-hand corner of this slide, and you can see that the vein has been strangled by a bit of fascia there, the deep fascia. So we have divided that, and once we divided that, we got a nice bruit rather than just a pulse, thrill rather than just a pulse. And on the right hand corner, there's this video which is playing, and you can see that there is a bit of a spastic segment in the vein, and I have not released any peri-adventitial tissue. There isn't anything to release in the swing segment. All I do is tap the vein a few times to release the spasm, and you can see it opens out very nicely without any further dissection. So coming to the first part of the question, I said that we're going to use the Doppler, both the ultrasound B-scale image and the Doppler component. In the lower of the in the three images on this slide, you see the vein, which I will image first using the B mode from the anastomosis still as proximally as possible to ensure that there are no stenotic areas. And then the color signal will show a nice spirolaminar flow through the entirety of the vein. The upper two images are that of the brachial artery, which has been imaged before and after the anastomosis. On the left, you see the flow is 52 ml per minute, having a triphasic pattern, and has got converted to a biphasic pattern with a significant rise in the flows in the brachial artery after the anastomosis, 407 ml per minute.
Now, could you help me out with every vascular access surgeon's nightmare? The anastomosis is done and the fistula is not working. I would do the following things at this point. First, check the blood pressure of the patient. In the presence of a low BP, there is no point in trying to explore a fistula. And this could have happened because of antihypertensives, removal of too much fluid during dialysis, or even undiagnosed sepsis. We have seen all these situations. What has been your experience? And if the BP is low, would you suggest giving a bolus at this point?
So while the earlier discussion was on a functioning fistula with, say, a pulse or a thrill and what to do when that situation arises, we are discussing completely of a non-working fistula, which means in my language there is no flow through this fistula. So look at the image on the extreme left and you can see that there is an obvious thrombus which is filled up the juxtaanastomotic region. So you need to look at the inflow and you look at the outflow. So when you dismantle this fistula completely, in the middle image, not of this fistula, you can see that the artery is completely cheese wired. Atherosclerotic artery, the intima, media, and adventitia are completely separated. So in this case, I had to, like I told earlier, tack down with 7-0 all the 3 layers through and through sutures, and then redo the anastomosis. On the extreme right is another very common condition, which if you notice early, you should manage it and tackle it. You can see that there's a valve in the vein. So you need to either avulse the valve or excise the valve, otherwise you'll end up having a thrombus exactly at the anastomotic point. So these are some scenarios which both on the inflow and the outflow side, which you can address if there's complete non-working of the fistula.
The patient has gone home with a functioning fistula and has come back after 10 days. In this time, we usually tell them to exercise with an AVF ball. Are weight-bearing exercises better? And what is your comment on this?
So I think the KDOQI is quite clear that the patient needs to perform isometric exercises. Most of our patients are quite keen on tearing up that fistula ball as quickly as possible with as many compressions as possible. This is the wrong way to do it. You need to squeeze, hold that ball in the squeezed position for at least 3 seconds and then release. This compresses the entire venous system in the forearm, pushing all the blood through the fistula and increasing the flow across the anastomosis. So that's exactly what needs to be done and not a competition to tear the ball up.
The patient has come back after 6 weeks and we have a happy situation of large visible veins. I lift the vein and I see a good venous collapse, which means that there is no outflow obstruction. Now, here is a patient in where we cannot see the vein. However, the vein is palpable, and when I close the outflow of the vein, then I have a good pulse augmentation. You can see my finger moving because of the flow. This is a vein I would declare as mature. How would you assess the fistula maturity?
So in my practice, the Doppler remains the cornerstone of examination at 6 weeks maturity assessment. We can start from the inflow, which is where I start. Look at the brachial artery flow. In this patient, you can see a good 1.2 liters. And then move on to the outflow, where we measure the vein diameters and the depth. As you can see, good vein diameters, more than 6 millimeters. And the depth is in the range of 2 to 3 millimeters, sufficient for our technicians to cannulate. Moving on, you can see I have documented some juxtaanastomotic stenosis in this patient, but with good brachial artery flows, you could wait, cannulate, and assess what happens to this fistula before you remove the catheter. And also, I have documented that this radiocephalic fistula has a predominant basilic drainage pattern, which means it may be possible that if the cephalic doesn't develop, they may not have cannulation segments higher up if needed. Once more, juxtaanastomotic stenosis in this patient, but with an adequate flow, in fact, 1.4 liters of flow, but very tight stenosis, and I have once again opted to cannulate first and then tackle the juxtaanastomotic at a later date if problematic. But what I've also mentioned above is the short cannulation zone. So this patient doesn't have much of a vein where they could move around with. So that's another thing which you can identify with the Doppler. And coming lastly to an obvious failure to mature, you can see here both inflow has very poor flows, 202 mils per minute, and the outflow has extremely small dias. And this patient will require some form of balloon assisted maturation if we're going to use this fistula. So overall, the Doppler helps us assess at a much more functional level, and I would say at the dynamic level within the fistula as to what's happening in the inflow and outflow, and certain other characteristics like depth and the drainage patterns.
Thank you, Dr. Krishnaprasad. We will summarize with that. Now, the vast majority of vascular access surgeons may not have access to a Doppler, or at least free access to a Doppler. And in that situation, clinical signs are extremely important and reasonably reliable. However, Doppler adds a wealth of information which becomes necessary if you are doing regular vascular access work.
Thank you, Maneesh. Like you emphasized again, the Doppler and its importance. I would say if you need to increase the complexity of the work which you're doing, and also you are constantly faced with fistula failures, or you need to manage failing fistulas, that is where Doppler would probably outdo clinical examination in that scenario. Thank you.
Thank you once again to Dr. Sujata and to ISU USI for allowing us to present this. Thank you.
And thank you, Dr. Maneesh and Dr. Krishnaprasad. I have a question for Dr. Krishnaprasad, that you do all the Dopplers for all your patients?
Yes, madam. So all the preoperative, intraoperative, and follow-up Dopplers are all done by me.
Yes, I think that would also be an important part of the training. Like you learned it abroad, or you developed a liking for after starting this vascular surgeries?
So I think a lot of our trainees are already exposed to the use of ultrasound in urology. It's just one step away to develop this interest in doing the work, like both Dr. Lalit as well as Dr. Uttam told about the point where we are losing vascular access patients to so many other specialties. But every time they have a problem, you're the first surgeon your nephrology colleagues refer them to. Or if you have an in-house dialysis center, you keep getting calls which you need to figure out on a day-to-day basis. So if we are going to look at ultrasounds of the kidney and tell patients that you have stones, you have tumor, I think the same needs to be done. And yes, this was something which I learned over many years. Some of it was learned abroad, but then once you do it, I think as you keep practicing it daily, you become proficient in understanding how the dynamics of each fistula.
Yeah, I suppose
I'll
yes,
just
we
add
should.
to that. I'll just add to that, ma'am. The learning curve for a Doppler is very small. It just depends on the availability. Once our residents start doing it, they just pick it up, and mostly in their first year itself, they have reasonable command over the Doppler. So it's a very short learning curve. But yes, the surgeon himself has to do it.
Yeah, I think, Manish, there are lots of questions in the chat box, but I have only one brief question is, you spoke of the cardiac subclavian steal syndrome, but also the subclavian itself can be narrow at the point, and sometimes. So do you do, in addition, a carotid Doppler and subclavian also, just as a screening? Dr. Krishnaprasad, he also said that means he would also do an echocardiography. So at that time, do you also evaluate these other vessels?
Where there is a history of, say, a central line insertion on the same side, or if you have done an earlier brachiocephalic which has closed off and now you're planning a brachiobasilic, then with the Doppler itself, you may get a window just below the clavicle and first rib, where you may be able to see the vein partly. So
Yeah.
there, yes, we would try and take a look at it, but it's not a complete
Not a
evaluation.
routine.
And no, and sometimes we send for CT venogram, but we haven't yet found it to be a reliable investigation. So whatever we find with Doppler, we do that.
Okay, Manish, I request you to please see the chat box and answer those questions.
Santosh had asked about a calcified artery. Krishnaprasad, would you like to take that?
So there are two thoughts on this wherever I have gone overseas, and then I will tell you my own thought process about calcified arteries. So there are some set of surgeons who love to do their fistulas on calcified arteries. The reason they provide is that a majority of the flow then runs off into the fistula, causing early maturity. And then there's another bunch which completely disagrees with this, saying that the calcified arteries in the rather in a normal fistula, over a course of time, the artery also, increases in diameter. So the flows increase both in terms of runoff to the fistula as well as runoff distally. But if the artery was to be calcified and the runoff to the fistula continues to increase, then there's a high chance of distal steal. So I ascribe to the second theory, which I just told you. I would probably be very judicious and not do fistulas in very densely calcified arteries, simply because I would probably be more worried about steal rather than having a functioning fistula.
I'll go on to the next question. For a pseudoaneurysm pending rupture, Krishna Prasad and I actually have a paper on this, so I'll suggest Rana you go through it. But the options include just excision or ligation of the vein. Sometimes where you have a very large, giant pseudoaneurysm with very large flows, you will actually have to repair the brachial artery. But if those facilities are not available, you don't have a graft available with you, then there have been situations where we have just ligated the brachial artery, both proximal and distal to the fistula. And in the two situations that I have done it, there has been no problem with flow to the distal limb because these are already hypervascular. Bobby, I'll agree that most of us now have the ultrasound because courtesy our anesthetists. So yes, we should start using it. That's all. Post-operative heparin. Go ahead, Krishna sir.
Yeah, so taking the question on post-operative heparin, I do not use it at all. The only time where I would use heparin is when I know as a fact that there has been a surgical error on my part, or maybe I believe that there was a reason for me to redo this anastomosis. So essentially, technical reason where I believe I'm going to cause a heightened thrombogenic condition in the patient. So the Virchow's triad that you're breaking. So that is probably the only time where I use heparin. It's been many years since I've used heparin while creating a fistula. You want to add to that, Manish?
No, yeah. So it treats the surgeon more than the patient. So it really doesn't do anything. We sometimes give ecosprin, sometimes add heparin, but we haven't seen any improvement in outcomes with that. Thanks, Chandra Singh. The next question is, do we make fistulas on the same side as a jugular catheter in situ? So if it is just a dialysis jugular catheter, non-tunnel, then there is very little reason to suspect a problem. But yes, the theory does say that you should choose the contralateral limb. But with a right jugular catheter, which is common, we very rarely see stenosis of the subclavian vein. So if there is a tunnel catheter, yes, we would evaluate and avoid that limb if possible. Right, Krishnaprasad?
So it's a call you take as you go along, and what are the options in your patient. Like I've shown you, many patients, there may be times when somebody has referred a patient to you. In fact, very recently, this has happened to me just a month ago. It's very fresh in my mind. This gentleman has come in from Jaipur. He had a fracture on his right upper limb. So for I don't know why that precluded. I mean, he said it's a humerus fracture. So I presume that the cast was below his below his arm, and they did not put in a tunnel catheter or even a temporary catheter on his right IJV. They opted to put in a left permacath, and I performed the Doppler. The central veins looked fine. There was good what I call as Valsalva feedback from the vessels, which is the phasic changes which occur in the subclavian and the uh, axillary vein. I made a fistula on his left upper limb, and did end up into trouble with venous hypertension. Had to take off the catheter, put it on the opposite side, and then do a plasty. He's awaiting a plasty. Sorry, I did the plasty, and there was complete occlusion of the entire uh, the left brachiocephalic vein. Complete occlusion. This is just the first and the only catheter he's had on the left. So I think judicious take would be maybe like what Manish said, not do it early on in your career, but then after some time you may have no options other than say doing it in sometimes. Yeah.
Saurabh, to answer your question, we've answered it partly about end to side to side, and graft. So I want to first emphasize that avoid grafts as far as possible. I have not done any graft in the last 5 years. If you have, if you're comfortable doing the brachiobasilic and the superficialization, the need should not arise in most patients. Next is end to side versus side to side. So this discussion we had, we don't want a very turbulent flow. A turbulent flow will cause more endothelial hyperplasia and more trauma in the vein. So you want the flow to be turbulent, which is only possible if you do an end to side. And that also has, as we showed in one of the slides, has to be done with a lot of care. Do not lift the artery. Make sure you do not do a heel to foot anastomosis. Krishnaprasad, you want to take the next question? Chandra Singh has asked, can you explain how to use a tourniquet?
So there are two ways, Chandra, to do this. In fact, Nick Instant from Birmingham has described a very beautiful technique, which I think was very ingenious. It's very useful if you tell your patients this. So he's called it the bottle cap technique. So all you do is take the bottle cap of any bottle cap available near you. If this emergency bleed or blowout happens in a patient's home, put the bottle cap on top of the bleeding area and then tie it down. In fact, actually works much better than just the tourniquet, because even if you use the tourniquet, the problem is you're cutting off the you need sufficient pressure both to cut off the inflow, outflow, as well as all the deep vessels coming in from the distally in the say arm. So if you don't do all that, you might end up having more bleed, and patients are really at a loss to understand how the tourniquet is just making things worse. So I think for the average man, I think it makes more sense, which is what I tell them nowadays. Any patient whom I believe needs an aneurysm repair, I teach them this bottle cap technique, and then over that they can just tighten down a band which will keep the bottle cap in place. Of course, if you seeing the patient yourself in the emergency, then it's well described that you can use an orthopedic band, or in fact even the very regular blood pressure cuff that we have easily goes up to 240. So you can clamp down on the upper arm and get control of your vessels. But you may sometimes find that you need to even still give pressure because the deeper vessels continue to flow into the into the blowout.
I would just mention that we would raise the pressure to 30 millimeters above the systolic blood pressure. And that usually tends to control things. And yes, that tourniquet is a very important thing if you're doing regular vascular access work. How to heparin solution? How to make the heparin solution? I assume so it's a 1:100 dilution. That's what we would use. I don't think you need to be very exact with that, and don't use too much heparin is what we'll say. Dr. Sujata
Yes,
wants
it's
to
one.
know about.
It's about 1 unit
Yeah,
per ml across. It's about 1 unit per ml. I would say. I mean,
yeah.
that's what all interventional guys continue to use everywhere. 1 unit per ml just for flushing the vein. That's more than sufficient.
What about papaverine and lignocaine? Krishnaprasad, to you.
Never use lignocaine. Papaverine for arterial spasm, yes. But for veins, absolutely no. I think we showed the video where just by tapping the vein, you can release all the spasms. Many years ago, I'm talking of almost a decade back, me and Manish used to do a lot of perivenous adventitial dissection. If I think that's the word which Manish had coined for it. And then it really very rapidly fell out of favor by both of us because it seems to tend to increase the juxtaanastomotic stenosis. You dissect all that fascia off the vein and you pretty much bare the vein and make it very susceptible for stenosis. So nothing on the vein, a papaverine for the artery, maybe if it feels too small in the radial setup or maybe the ulnobasilic setup, but other than that, no.
So that brings us to the last question. If nobody has any further questions, then I think we can close. Dr. Sujata?
Yeah, I wanted to ask you that suppose you expose the radial artery and the cephalic vein at the snuff box, and you find that contrary to your clinical judgment or a Doppler, the vein and the artery are not good, then do you immediately proceed to a higher level, or
Yes, ma'am. So
you
over a
take
period of
a blanket consent that way, or you?
Yes, ma'am. So over a period of time, what we've realized is that this happens more often than we want it to. So most of the patients I would post as radiocephalic, SOS brachiocephalic. We are lucky that our anesthetist gives brachial block, so it really doesn't matter to the patient. But radiocephalic, then distal forearm radiocephalic, then brachiocephalic. But we do
Then
take a
break
second
yourself.
consent. We do take a second consent. If it is a brachiocephalic, SOS brachiobasal. So at least one step above is planned and we take the consent.
So in the forearm, sometimes the radial artery has to be brought out at a little superficial level. So normally you said you do not disturb the vessels and their adventitia. That would be at the distal forearm, but in the middle of the forearm where you dissect the radial artery, don't you find it is little deeper and it has to be separated out of a facial covering and then brought and made bit superficial?
So, ma'am, the point at which I said that the accessory cephalic and cephalic joint, the radial artery really is not very deep. What we have to do instead is that there are these fascias on top of the artery. That needs to be divided very generously. The artery should not be sort of kinking through the fascia.
So I
Yeah,
think
and
the
how long do
question
you?
can.
Yes.
So, Dr. Sujat, I think the point where you are trying to make your anastomosis is mid forearm. Manish
Mid
is
forearm.
talking of the junction of accessory and cephalic, which is almost a lower forearm. And
Yeah.
there is no question of bringing the artery up. It's already quite superficial. I think your problem is when you're doing mid forearm.
Mid
Now,
forearm.
with mid forearm, there is a tricky part here. You need to consider what is it that you're trying to give the patient. Because if you do a mid forearm fistula, your venous cannulation area is in the upper forearm and sorry, arterial, and your venous cannulation is going to be in the arm. You're crossing two different segments of vein. You are jeopardizing your next fistula. So if you're very clear that your succession fistula is not going to be a brachiocephalic, go ahead and do it in the mid forearm with the understanding that you're using two different segments of vein in the forearm and arm. And in that case, what I do is I don't bring the vein up, dissect sufficient length of I don't bring the artery up, dissect sufficient length of the vein and let the vein dip into the artery. You will have to
Different.
divide the muscles a bit. Your vein configuration goes down vertically, like what I told, onto the artery, like in the image which I showed, but do not lift up the artery, because then, as an interventionist, when I come back and try to do a fistuloplasty, believe me, it's a nightmare if the artery has been mobilized. You keep fiddling and trying to get your wire into the anastomosis. It's quite tough if you completely mobilize the artery. So
Yeah.
I think
I have
that's
one
the
more question
situation
to
which you're
you.
asking.
Yeah, right. One more question to you is you also mentioned that after doing the AV fistula, sometimes we find that the vein is compressed by a few bands of some tissue. It could be subcutaneous tissue, some fibrous tissue. So, for how long do you free the vein? How many centimeters, or till you see that the flow is clearly going across? Because sometimes then you have to dissect this vein in the subcutaneous tissue, because that's what I have found a problem when operating. uh, you understood
So
my question?
yeah,
uh,
I understand your question. So now again, it comes back to what is the optimal angle at which your vein is meeting the artery. So if you again look at literature now, uh, there are plenty of people across the world using something called a vascu device. A vascu device is a metal, uh, scaffolding which you place around the vein so that the angle at which the vein meets your artery is 45 degrees. The claim being that if you angulate the vein at this particular, angle to the artery, then the amount of juxtaanastomotic stenosis is less. So if you think your vein is angling nicely away, then you may not need too much of dissection. But if you think your vein is almost at 90 degrees, then you probably may need to release enough, whatever subcutaneous tissue or the deep fascia, so that you create 45-degree angle with the artery. That is believed to create the least amount of turbulence around the juxtaanastomotic region. Hopefully that kind of give you
yeah,
a more quantifiable answer.
yeah, thank you. I
There
think
is,
any more questions, Manish, in
there
the
is there is one question from Dr. Abdullah sir, I think from Maldives. He wants to know how long the fistula lasts. I would say that is anybody's guess. But yes, it depends. Once a fistula has matured, it depends largely on how good your dialysis technicians are. So we've had patients on 10 years on dialysis. We've had patients who close off in 2 months. So there is really no answer to that.
I think care of a fistula is a very critical part, which is constantly missed. And I've been making a huge effort, and I think even on Manish, we try to talk to our technicians. I call them up and I tell them that they need to change their cannulation zones, inform us early if they think they're having problems, send patients over to us for a regular, Doppler and ultrasound assessment. I think all this paves the way for having a more smoother post-operative life of your fistula, rather than having tumultuous, events occurring in a lot of these patients, especially when they don't come and see you very frequently. Then believe me, I think all of us have had the Saturday evening call where the thrombus has occurred, and then you are called at exactly 5 o'clock in the evening to figure out what you need to do to these fistulas.
true.
Can,
Yeah.
can I ask?
Yes,
Yes,
Can
sir.
I
yes,
So there
Uttam.
is
First of all, really, I congratulate both of you for this nice webinar. I learned a lot. I have just
thank you.
some a general question. So, what is your preference of antibiotics and how long you give?
So one is we give a single dose of cefazolin. If not available, then cefuroxime. Basically, a single dose of gram-positive cover. The only thing I would like to point out is if this patient has had a catheter, he's on dialysis, and he has had fever, then unless he has been completely treated for that, has a negative blood culture, we will not do the fistula. We have done it, and we've ended up with infected pseudoaneurysms.
Thank you.
So there is one question online. I think that should be the last question. Abhineet wants to know, does the use of vein dilator help if vein is of not of good caliber? I would not dilate any vein. If a vein is healthy, it will dilate on its own. But Krishna Prasad, your opinion.
So I hydrodistent all my veins, and I don't use a vein dilator. Just do a hydrodistension of every single vein anastomosis which I perform, whether it is radiocephalic or brachiocephalic. Of course, the basilic transposition you will hydrodistend anyway because you want to check for leaks. So that's been my practice over the last 12, 14 years, I think.
So if that's all, then we can close. Dr. Sujat.
Yeah. Yes, so thank you, Maneesh and Dr. Krishna
Mhm.
Prasad, both of you, for this wonderful webinar. And yeah, we all of us continue to learn, and it's nice that you are taking up this. And I hope more of our junior colleagues and students do learn the technique of Doppler, and we retain this to urology, vascular anastomosis. And thank you very much to the President and the Secretary, Dr. Uttam Mete, for attending this webinar, and all the participants here. Thank you very much, and good night.
I have only
Thank you.
one suggestion. Like
Yeah.
you would have shown us a little bit of small video clips of your technique of fistula formation, or that would have been a little bit of some help for the beginners, you know.
We'll
And we
try
could
and
definitely have another session.
yes, yes, sir. Next time.
You can just add it to the presentation, because this thing would be going on YouTube. So if you could add the videos, and if you have them ready, we can just combine them with
Okay,
your
ma'am. We'll
half
take a little. We'll take a little time and get it done. We'll do that.
Sure. Thanks a lot.
Thank you.
Thank you
Okay.
very much. Good
Thank you.
night. Good night.
Thank you. Good night.
Yep, good night. Thank
Thanks,
you.
Krishna.
See you
Thank you,
again.
sir. Thank you, sir.
Thank you.